Ovarian cancer: the best treatment options. Ovarian cancer is a relatively uncommon type of cancer that arises from different types of cells within the ovary. The most common ovarian cancers are known as epithelial ovarian cancers. Other types of ovarian cancer include ovarian low malignant potential tumor, germ cell tumors, and sex cord stromal tumors. Inherited mutations in the BRCA1 and BRCA2 genes greatly increase a woman's risk of developing ovarian cancer. A gynecological oncologist is a specialist with expertise in the management of ovarian cancer. Most ovarian cancers are diagnosed in advanced stages because there are no reliable early symptoms and signs of ovarian cancer. Even in more advanced tumors, symptoms and signs are vague and nonspecific. There are no reliable screening tests for ovarian cancer. Treatment of ovarian cancer involves surgery to remove as much of the tumor as possible and chemotherapy. The term ovarian cancer includes several different types of cancer that all arise from cells of the ovary. Most commonly, tumors arise from the epithelium, or lining cells, of the ovary. These include epithelial ovarian, fallopian tube, and primary peritoneal that coats many abdominal cancer. These are all considered to be one disease process. There is also an entity called ovarian low malignant potential tumor. These tumors have some of the microscopic features of a cancer, but tend not to spread like typical cancers. There are also less common forms of ovarian cancer that come from within the ovary itself, including germ cell tumors and sex cord stromal tumors. All of these diseases as well as their treatment will be discussed. Epithelial ovarian cancer. Epithelial ovarian cancer accounts for a majority of all ovarian cancers. It is generally thought of as one of three types of cancer that include ovarian, fallopian tube, and primary peritoneal cancer. All three tumors behave, and are treated the same way, depending on the type of cell that causes the cancer. The four most common cell types of epithelial ovarian cancer are serous, mucinous, clear cell, and endometrioid. These cancers arise due to DNA changes in cells that lead to the development of cancer. The serous cell type is the most common variety. It is now thought that many of these cancers actually come from the lining in the fallopian tube, and fewer of them from the cells on the surface of the ovary, or the peritoneum. Ovarian low malignant potential tumor. Ovarian tumors of low malignant potential account for about 15% of OC. They are most often serous or mucinous cell types. They often develop into large masses that may cause symptoms, but they only rarely metastasize, that is, spread to other areas. Often, removal of the tumor, even at more advanced stages, can be a cure. Germ cell ovarian cancers. Germ cell tumors arise from the reproductive cells of the ovary. These tumors are uncommon and are seen most commonly in teens or young women. This type of tumor includes different categories: dysgerminomas, yolk sac tumors, embryonal carcinomas, polyembryomas, non-gestational choriocarcinomas, immature teratomas, and mixed germ cell tumors. Stromal ovarian cancers. Another category of ovarian tumor is the sex cord stromal tumors. These arise from supporting tissues within the ovary itself. As with germ cell tumors, these are uncommon. These cancers come from various types of cells within the ovary. They are much less common than the epithelial tumors. Stromal ovarian cancers include granulosa stromal tumors and certainly egg cell tumors. Ovarian cancer risk factors. Risk factors are related to two major categories: menstrual cycles and family history. The more a woman ovulates over her lifetime, the higher her risk of ovarian cancer. Thus, starting her period at a younger age, ending her period at a late age, and never getting pregnant are all risk factors. It was once thought that infertility patients who underwent preparation for IVF were at increased risk, But this has since been shown not to be the case in a large comprehensive review of the subject. Ovarian cancer symptoms and signs. Screening tests are used to test a healthy population in an attempt to diagnose a disease at an early stage. Unfortunately, there are no good screening tests for ovarian cancer, despite extensive ongoing research. Imaging and blood tests should not be used as a screen, as they are inaccurate and lead many women to surgery who do not need it. They are false positive tests. Diagnosis of ovarian cancer is often suspected based on symptoms and physical exam, and these are followed by imaging. The signs and symptoms, when present, are very vague. These can include fatigue, getting full quickly, abdominal swelling, clothes suddenly not fitting, leg swelling, changes in bowel habits, changes in bladder habits, abdominal pain, and shortness of breath. As mentioned above, these symptoms can be very subtle and vague, as well as very common. This only makes diagnosing the disease that much more difficult. Some studies suggest that the average patient with ovarian cancer sees up to 3 different doctors prior to obtaining a definitive diagnosis. Often, it is the persistence of the patient that leads to a diagnosis. OMT and some benign tumors can present with similar symptoms. In addition, they are often seen with very large masses in the ovary. Often these masses are large enough to cause bloating, abdominal distension, constipation, and changes in bladder habits. In the more uncommon ovarian types, symptoms are similar. Sometimes, granulosa cell tumors can occur with severe pain and blood in the belly from a ruptured tumor. These can often be confused with a ruptured ectopic pregnancy, as they tend to be found in women of reproductive age. Ovarian cancer diagnosed. Often vague symptoms eventually lead to a clinical diagnosis, or one based on suspicion generated by exams, laboratory tests, and imaging. However, an accurate diagnosis requires some of the tumor to be removed, either by biopsy, or preferably, surgery to verify the diagnosis. Often a high clinical suspicion can trigger a referral to a gynecological oncologist. Various types of imaging studies can be used to diagnose this disease and lead to tissue sampling. Ultrasound and CT scans are the most commonly done studies. These often can give images that show masses in the abdomen and pelvis, fluid in the abdominal cavity, obstructions of the bowels or kidneys, or disease in the chest or liver. Many times this is all that is necessary to trigger a referral to a specialist, as the suspicion for ovarian cancer can be quite high. PET scans can be used, but often are not necessary if a CT scan is able to be performed. Ovarian cancer staging determined. Staging is the process of classifying a tumor according to the extent to which it has spread in the body at the time of diagnosis. Ovarian cancer staging. Stage 1, limited to one or both ovaries. Stage 2, limited to the pelvis. Stage 3, disease outside of the pelvis, but limited to the abdomen, or lymph node involvement, but not including the inside of the liver. Stage 4, disease spread to the liver or outside of the abdomen. Complete staging of an ovarian cancer includes hysterectomy, removal of the ovaries, tubes, pelvic and aortic lymph node biopsies or dissection. Biopsies of the omentum, and peritoneal biopsies. Treatment for ovarian cancer. Epithelial ovarian cancer treatment most often consists of surgery and chemotherapy. The order is best determined by a gynecological oncologist. Surgical treatment. Surgery consists of an effort to remove all visible disease in the abdomen, commonly called surgical debulking. If one imagines a handful of wet sand thrown on the ground, you will see small piles and bigger piles. This is often how the abdomen looks when in surgery. It is the job of the surgeon to remove as many of these masses as possible. This surgery usually results in removal of both tubes and ovaries. The Uterus, removal of the omentum, lymph node biopsies and any other organ involved in the disease. This can mean a portion of the small bowel, large bowel, liver, the spleen, the gallbladder, a portion of the stomach, a portion of the diaphragm, and removal of a portion of the peritoneum. Done properly, this can be a very extensive surgery. The patients who live the longest have all of the visible nodules taken out at time of surgery. To accomplish an optimal debulking, at minimum, no individual nodule greater than 1 centimeter should be left behind. If this cannot be done, the patient is brought back to the operating room for a second surgery after a few rounds of chemotherapy.